Can I share my screen to be sure my slides will work?
Yes. I just give you, wait 5 minutes. Just I am making the YouTube broadcast in minutes, and then I give you, yes, thank you. I just make you as a host. Now you can check whether you can use the screen. You are a co-host now.
Okay.
Just the green button on the down.
Yeah, no,
Yes. Dr. Ajoy also is there. Hi, Dr. Ajoy. Is it possible?
I don't see my my board. Let's see.
سلام دکتر جان.
سلام، خوبی شما؟
قربان شما. شروع شد.
I can't share my screen. Let's try it again. I mean, usually when you hit the share screen, I can go directly to my you have to allow me to share my my screen. Yes, it's only allowing me to share the screen, the Zoom screen. It's not allowing me to share my my own screen or my okay, can you see it now?
Yes.
Okay. You can see it now?
Yes, we can see it.
Okay, and it advances. Okay, all right. I don't know why it wouldn't go the first time. So, yeah, just let me know when you're ready to start and we can go.
We have to wait a few minutes for some other participant to come, and our educational director also, he was on the way. In few minutes he will reach to us. And thanks, Dr. Ajoy, also from India, is there. How are you?
I'm fine, thank you, Ali. Thank you very much for sharing the link. Yes.
Yeah, you're welcome. Very happy that we can see you, and you are very active in the TMJ. I know from a few years back, and saw you in Iran also at the AO meeting for TMJ surgery. It was very nice. I know you are doing very good work. Very, very thanks to Dr. Louis. He has accepted our invitation. I know he's one of the most pioneer in the USA in TMJ total joint replacement. And we are very happy that we have him here with us. And the problem with Iranian, we got some problem with sanction. We cannot go so easily to USA to join these courses. But last year I got the opportunity to join his course at Vienna. Doctor, remember? Yes,
yes.
with the NEEDS, Dorothy NEEDS also was there, and a few from Spain. Yes, very good. If it is possible, doctor, can you let me to be host again, because now you are a host.
Oh, okay.
You make me a host. I just show a few PowerPoint for some photo from Iran till the people are coming.
Okay, go ahead.
Okay, thank you. You just press my photo, and the top there is a blue dot, and
Yeah.
the blue dot you make me as a co-host or host. Is it enough?
Let's see.
Is done?
I'm trying to, let's see.
There is a 3-dot blue on my photo.
Right.
Yes.
Yeah, I see. It says mute,
make,
stop video, chat, rename.
You make me as a host.
It doesn't say that.
On the
Let me go to the top here. No, it doesn't say that. That's none of the choices.
It is not possible on that too.
No, it doesn't. It doesn't. It doesn't. The only other thing I can do is hit the stop share.
You stop share and do that whether it's possible.
Okay.
Now, let me see. Now you do the same thing on my on the mute. On the next to mute, there is a 3-dot blue. See whether it's possible to make me as a host or co-host. No?
No.
Okay, don't forget it, no problem. Okay, you can use your screen again. You use your share screen. Yes.
See if I can get back to. No, I can't. It doesn't allow me to do that.
Okay,
Doesn't
no
allow
problem.
me to get you as co-host.
Okay, no problem. Just inform few other people. No.
So what I see people coming in, it says admit. So I'm just hitting admit.
Yes.
So I'm admitting.
Yes, you admit them. You can admit them.
Yeah.
Yes, you can admit, because now you're a host. You have to admit them also.
Okay. So I'll continue doing that. There are 9 people so far.
Yes, yes. I don't know what happened. Previously, we used to have 2 co-hosts, a few co-hosts.
Yeah, I've never seen this happen before.
Yes. Previously, we used to have lots of other opportunity. I don't know what happened. And this is a problem for you also. You have to admit others.
No problem.
I'm very sorry. Yeah,
I'm trying to see if there's a way to co-host.
Yes. See once more again, if you can make me as a co-host, I can do the same also.
Yeah, but I can't see how. I mean, on that.
Ali,
Yes.
I can also admit from here. I do not know how it is happening, but I can also admit.
Okay, you can also admit you do it.
Yes.
I don't know what's
Yes, I'll
happened.
do it. I'll do it. Lou, you don't bother about it. I'll do it for you.
Oh,
Yes,
great.
yeah,
Thank you.
yeah, thank you.
Hey, Joey, can you try to go to Alireza's picture and see if you can make him a co-host? The three dots next to his picture.
Yeah, I previously got a lot of options as a co-host. You can make up to 10 co-hosts, but now I don't know what happened to this.
No, that option is not coming, Lou.
Yes, yeah, that's
not
the problem.
coming. Yeah.
Yeah.
Okay, we won't wait. And Dr. Ajoy, please take care of people are admitting.
Yes.
Okay,
Yes.
thank
Yes,
you,
sir.
because I cannot do it now. And because previously I used to make the speaker as a co-host and they can share a screen and all this. But now I don't know what happened to this option. Anyway, we will forget this and we are going to start our meeting. Today we are very happy to have the Professor Lois Mercurii from USA, and very thanks to him to accepting our invitation from our Association of Oral and Maxillofacial Surgery. He was a professor of surgery at Loyola University Chicago Medical Center and an ex-member and oral and maxillofacial surgery faculty, University of Illinois, Chicago. An ex-chairman and Department of Oral and Maxillofacial Surgery, Chicago Medical Research Hospital. And now he is an adjuncted professor at Department of Bioengineering, University of Illinois, Chicago, and visiting professor at Department of Orthopedic Surgery, Rush University Medical Center at Chicago. And I know him for more than a few years. And last year I got the opportunity to be attending one of his course at Vienna on TMJ arthroscopy and open surgery. He have done lots of research on TMJ, and he's one of the most important pioneer in the field of alloplastic and TMJ at USA, and the TMJ total joint replacement in USA because of his work. He is a very active member of KLS Martin Educational Center, and we are really very happy. I don't know whether our Director of Education at Department of Oral Maxillofacial Surgery or Association of Iranian Association, Dr. Parris, if he's there and he wants to say any words, we will be very happy. Dr. Parris, are you there? I think he's on the way also. Dr. Lois, please start your presentation. Thank you so much.
Thank you, Alireza.
You're welcome.
I really appreciate the opportunity to make this presentation. I would like to begin by hoping that every one of you, your families, your friends, and all of your colleagues are continuing to stay healthy and are well during this very difficult time around the world. Now we're not able to advance the slides here.
Yes.
There we go. Okay.
Yes, yes.
All right. Thank you for the kind introduction. I really appreciate it. I've finished my clinical practice about 10 years ago, and since that time, I've been involved with the orthopedic surgery department and the bioengineering department at these two universities here in Chicago. And I'm hoping to be able to bring some science to what we've been doing clinically with temporomandibular joint replacement. And so I'm going to sprinkle in some of the research that we've done along with some of the clinical cases to kind of bring you up to date on where we are with temporomandibular joint replacement. I am a compensated clinical consultant for TMJ Concepts, as well as a minority shareholder in that company. And this is what we're going to talk about today. We're going to talk about alloplastic temporomandibular joint replacement, some of the clinical outcomes up to date, what are causes for design and material failures, you as the surgeon, why you cause failures, what are the limitations with using temporomandibular joint replacement devices, and then just very quickly talk about some of the past, present, and future research. Let me first introduce you to Sir John Charnley. John is the father of orthopedic total joint replacement with alloplastic devices. And without him, the practice of modern orthopedic surgery would be unthinkable. This is Peter Quinn and myself a few years ago. I helped develop the TMJ Concepts device, which is on top here. And Peter helped develop the Biomet device here. And both of us believe, as Sir John Charnley said, the modern practice of maxillofacial surgery should be unthinkable without alloplastic TMJ devices. It's interesting that Peter and I were both born in the same town in Pennsylvania. Okay, we're having trouble with advancement. My slides are not able to advance. There we go. Okay.
Yes.
All right. What are the goals of temporomandibular joint replacement? Well, you can read those there, but the most important one is the top one, to improve function and form. It is not to take pain away. If you do this just to take pain away, you're going to fail. So I think that's one of the most important things that we've learned over the 30 years that I've been doing this. You never promise a patient that you're going to relieve their pain. It's impossible. So what are the advantages and disadvantages of alloplastic joint replacement? Well, the advantages are that certainly they're available. You just have to buy them. There's no donor site. So it's not like a rib graft or a hip graft or a fibula where you have to do another operation on another site. So it takes a lot less longer, which is important. We'll talk about that. It conforms to any given anatomy. Certainly, if you have a custom device, you can make it in any shape or form, and we'll show you that. But importantly, it's not susceptible foreign body giant cell or systemic disease. Okay, there's no way that the cells in the body are going to attack the metal and plastic and cause them to degenerate. Now, we'll talk a little bit about corrosion and those kinds of things. That's a whole different issue. But it makes no sense to place a rib or a fibula or a hip graft or any other form of autogenous tissue in a joint where you have active disease, because that disease is going to destroy whatever autogenous tissue you place there. And finally, one of the most important advantages, you can start your physical therapy almost immediately. My patients started physical therapy 24 hours after the device was placed. We all know that from our orthopedic studies, that the earlier you can get a patient to function with an alloplastic device, the better the outcomes are, the less pain they have, because they develop less scar tissue around the device. So this is really important. And we know with rib grafts, we're going to keep those patients in fixation really for 20 weeks if you really want that rib to solidify. The disadvantages are obviously the cost. These are very expensive devices. And the reason they're so expensive is a simple supply and demand issue. For instance, in the United States now, 1.5 to 2 million knees and hips are done. So the cost of those devices are a lot less. Also, most of those devices are modular, meaning that they're not custom, meaning that they're stock pieces. So the company can make them, a whole bunch of them at one time. We'll talk about that a little bit more when we get to 3D printing. The other concern with an alloplastic device is there's material hypersensitivity. This is an issue that has plagued orthopedics from the time of John Charnley back in the 1960s. We are still working on this. We could talk for 2 or 3 hours just about material hypersensitivity. Unfortunately, we don't have the time to do that, but it is an issue. Wear is an issue, and we'll talk a little bit about wear. You not only have particulation of the material as these devices are being used, but you also have ions coming off from the metal that's being used. And we'll discuss this a little bit when we talk about research. Longevity, how long do these devices last? Any device that's placed in the human body is going to wear out, particularly devices that are under function. The latest studies that we have was a 2015 paper that showed with a custom device, they appear to last about 20 to 25 years. We're doing a 25-year follow-up study to see how long that will last. And the reason I think that we have greater longevity with custom devices or with TMJ devices in general is because the loads that are delivered to them, the functional loads, are exponentially less than the loads delivered to the knees and hips. And finally, are they really only able to be used in skeletally mature patients? We'll discuss this in a moment. So, what are the indications for a total joint replacement? Well, it's arthritis, both low, meaning osteoarthritis, and high inflammatory or rheumatoid arthritis. Ankylosis, both fibrous and bony. Failed autogenous grafts, and the most failed graft that we see is the costochondral graft. Failed alloplastic devices. We'll talk about why these devices fail. And then lastly, loss of mandibular vertical height due to bone resorption, trauma, developmental abnormalities, or pathologic lesions. And we'll give some examples of all of that. What are the relative contraindications? And I call them relative. They're not absolute contraindications, but if you look at the first 4, those would be the same relative contraindications or things that you would think about when you do a dental implant. Okay? Documented material hypersensitivity is not real common with titanium, so you wouldn't consider that with a dental implant. But because of the materials, and we'll talk about the materials in a few minutes, we have to think about material hypersensitivity again. And this ugly thing will raise its head again over and over and over. And finally, age is a relative contraindication. This is a paper that was just published in the OOO. It's a study that we did along with our colleagues from Maryland and Oklahoma, where we looked at patients from around the world, skeletally immature patients. And what we're talking about skeletally immature here, we're talking about females below the age of 14 or 15 and males below the age of 17 to 19. And these were patients who had alloplastic devices put in place. Most of the reasons for this being failed rib grafts that were placed for ankylosis. And these patients, 80% of them continued to grow. The 20% that didn't grow didn't have a muscular matrix. So these were patients that had developmental deformities. So this is a paper, one of the first papers that talks about this. We also have a paper in the plastic surgery literature where we've looked at patients with craniofacial anomalies, both adult as well as pediatric, with using these devices. So as we say at the end of our discussion here, this is a study that hopefully will allow us to start looking at this as a means of dealing with some of these patients. And we think the primary indication would be failed multiple rib grafts in children where the rib has either ankylosed or overgrown. But these studies will be continuing. So let's look at the literature about these devices. Do they work? What does the literature say? What's the evidence that these devices work? Well, this is a review, a meta-analysis that was done back in 2017 with these three devices. This device is no longer available. It's off the market, and I'll show you why in a few minutes. So these are the Zimmer Biomet and the TMJ Concepts devices. The results were favorable. As you'll see in all of these papers, here's another meta-analysis done in 2018. This meta-analysis shows that stock and patient-specific or custom devices have the same outcomes. They decrease pain and increase function. Here's another one from 2019, where the data was compared between a custom and a stock Zimmer Biomet. It showed comparable data, albeit this is only a 6-month follow-up study. But again, the data seems to be comparable. This is a study that was done looking at the Zimmer Biomet versus the Christensen or the Nexus device. And it showed that the had fewer device component failures with the Zimmer Biomet system than with the Christensen system or the Nexus system, which as stated was no longer on the market. And finally, here's a more recent paper done by a group from Belgium, where they showed that custom total joint replacement devices were more frequently chosen for cases with more significant joint degeneration. So the more complex cases required a custom device. And they also concluded that custom devices provide significant operative and patient-centered advantages over stock implants. This is a study that I found to be interesting. This is a review of the literature from 1995 to 2020, where we looked at 29 papers that had almost 2,300 cases with a mean follow-up of about 5 years, where we had significant improvement in both subjective and objective parameters. But the most important thing, and this is the thing that orthopedic surgeons are looking at very closely, is the patient's report of their own outcomes. The metrics that we look at are much different than the metrics that a patient looks at. And so you measure patient metrics by looking at their quality of life. What do they think their quality of life has improved? And in all of these papers, there's a 79% improvement in quality of life. So that shows you that despite the subjective and outcome variables, patients still think this is a good thing that they did. And that's really important. Okay. Progress. I think you may have to give me a push here.
Pardon?
My slide's not changing.
You again go back and just make a slideshow and change. Come back to a slideshow. Previous, next. You can put the next.
Yeah.
With it.
See if that, I can't get the cursor to go where I want it. There it is. Okay.
Yes.
All right. So it should become apparent that the phobia around using these devices is really not warranted. So temporomandibular joint replacement represents a viable and stable long-term solution for craniomandibular reconstruction in patients with end-stage disease. But this is a group of my colleagues from the UK, and we sat down and we said, there's a whole bunch of devices being made all over the world right now. Let's take a look at them and see what design is being used, what the materials are, how they're testing them, and those kinds of things. So this is a very busy slide, but this is a list of all the countries, all the manufacturers, and whether they're making a stock or a custom device. So we have 18 countries, 38 devices, 9 of which are stock and 29 of which are custom. So it tells you that people are starting to realize that maybe we should be using custom devices for complex cases and stock devices for very simple cases. Now, what's the difference between a stock device and a custom device? Well, I'm not going to go through each one of these, but there's a few of them that I think are important. First of all, longer surgical time with a stock device, because you as a surgeon have to make it fit. Whereas with a custom device, it's made to fit, so we have a shorter surgical time. Why is that important? Well, from the orthopedic literature, it's well documented that the incidence of surgical site infection increases the longer it takes for you to do the surgery. Okay, so that's important. The second one here that's important is that you have to remove a lot of bone to make this thing fit. Sometimes when you remove all that bone, you remove bone that's important for stabilization of that device with the screws. There's a tremendous potential for micromotion, again, because you have to make it fit, as opposed to something that's made to fit. Now, micromotion is comparing it to a dental implant. If you place a dental implant and it's not stable from the time you place it, you know that that patient's going to come back in a few days or weeks, and that implant's going to be in their hand, or you're going to be able to take it out very easily. So it's the same thing with a TMJ device, and I'll show you that clinically. There's no posterior stop, and we'll talk about that, and I'll show you an example of that, where the condylar component of a stock device can slip behind it and get into the auditory canal. So again, these are those cases that I talked about before, the countries, the devices. But the point I want to make here is if you look at the fossa component, these are the elements that make up the fossa component. For the most part, it's all ultra-high molecular weight polyethylene, which is the material that has been used for decades in orthopedic devices. So that's the polyethylene component or the fossa component bearing surface. And these are the condylar components. Most of them are chrome, cobalt, molybdenum, which is a cast alloy. And we'll talk about that in a couple minutes. And most of the ramal components are titanium alloy, because titanium is a good material to use for this. Some of them are different, and we'll talk about some of those differences. Here we go again. I'm sorry, I don't know why.
Okay, yeah, no.
Not advancing. Okay, so these are some pictures. I apologize that all the pictures aren't really pretty, but this is what we can get. The only thing we can get out of the literature. Once again, we're not able to advance. And here's some more. These are the two predicate devices. And you can see most of these devices look exactly the same. And the reason for that is there's really only one way you can put these devices in. So what conclusion did we come to after looking at all of this? Well, we first determined that all systems are not equal because of their design, their material composition, their preclinical laboratory testing, their manufacturing methods, the regulatory status. Actually, only 4 of those 18 countries require any regulatory regulation of the devices, and the reporting of the clinical outcomes. There were 1 or 2 cases for each device. This is not a reasonable way to handle it. So this is a good quote. The only real mistake is the one from which we learn nothing. So what have we learned so far? Well, we know that these are the 4 elements of failure. We have a failure of concept. We have a failure of embodiment, meaning the design and the materials that are being used, a failure of implantation technique, and a failure of because of the limitation of technology. This failure of implantation technique is all on the surgeon. And it is the #1 cause in orthopedics for failure of devices. So I'm going to talk about each one of these and give you examples of why devices fail. Here we go. Maybe. Okay, failure of concept. This means that it's a bad idea. The device cannot satisfy the fundamental principles of anatomy, physiology, immunology, and/or biomechanics. The best example of this was our problem with Proplast Teflon, which was an interpositional material, and silicone rubber. Okay, these are two materials that should not be used under function. In fact, John Charnley showed this back in 1964, and we didn't heed it. This is the second one. This is also an interpositional material. This is the fossa eminence device, the old Christensen fossa eminence device, where he pitted bone against metal. And this is what happens. You have tremendous loss of bone because metal against bone, the winner is always going to be the metal because metal is dead, bone is alive. The next, get to next. Or other failures of concept, where we're talking about a very thin neck for a condyle, a very thin ramal component, and the use of polyethylene. This is not polyethylene. This is polymethyl methacrylate. Okay, this is denture material, clear denture material. And when this device was devised, the idea that the surgeon had who devised this was that the condylar component would wear down and remodel just like the normal temporomandibular joint does with bone, that you get a remodeling process. Well, that's not reasonable because what happens to all of these particles that get out into the periarticular tissue? And finally, this was a metal kind of device that only fractured. A bad idea to use metal against metal. Here's one that's coming on the market. It has a cantilever, which is going to fail, and multiple moving parts. Okay, you can't have multiple moving parts. This has been shown in orthopedics over and over again. This device will fail. Here's a device that uses stainless steel. This is the most highly corrosive material that we have when you put it in the body. Here's another one that where all the fixation is at the top of the device. When we know from the literature and all the finite element analysis studies that have been done, is that the most force that is placed on this device, because the moment arm physically is at the top, that the top screws are the most important, and that's where all the force is. So you want to buttress the top screws by placing all of the screws down here to take some of the load off of this. These devices will dramatically fail over time. So let's skip to embodiment. So we had the bad ideas. Now we've got the bad designs, the bad materials, the bad manufacturing. And so we're dealing here with metals. And I have to give you a quick course in metals because you have to understand the difference between a cast device where the grain size, that the material is melted so that the grains expand. And as the material cools, the grain structure changes. It shrinks down. Cobalt chrome is a cast alloy as opposed to titanium. Titanium is a wrought alloy. What wrought means is that these materials are not melted until we get to 3D printing, and we'll discuss that. But the typical form of titanium that's used in most devices that are not 3D printed, these materials are pushed together. So they have finer grain structure, higher tensile strength, better fatigue life, and greater ductility, and a greater potential for osseointegration. That's why we use titanium to make dental implants and not chrome cobalt. There's a 40% greater osseointegration with titanium than there is with chrome cobalt. What we decided to do in our lab is characterize the implant alloy microstructure of the TMJ chrome cobalt and titanium alloy components, because all of these components in all of these devices are not the same. So I'm going to quickly go through this. I don't want to bore you with it, but I think it's interesting, and for surgeons, they ought to know this kind of stuff. We're looking at grain size and hard phases. The grains are these little structures that you see here. Okay, the hard bodies are these structures, these little white things that you see here. So this is specimen A, this is specimen B, and this is specimen C. 3 different companies, 3 different chrome cobalt materials under scanning electron microscope. And when we're looking at hardness, abrasive wear, corrosion resistance, and fatigue behavior, we want the finest grain structure, the lowest hard bodies. So if you look at these 3, specimen A has a grain size of 7, specimen B 5, and this actually is 1 whole grain of specimen C. So the only one that satisfies us in terms of these variables is specimen B, because we see small grains, we see very, very few hard bodies in here. This one is full of hard bodies and it's 1 giant grain. So that shows the difference under scanning microscopy, electron microscopy, of chrome cobalt conduits. So 3 different companies, 3 different chrome cobalt specimens. So look at titanium. We use electron backscatter diffraction because this is the scanning electron microscopic picture of specimen A from 1 company, specimen B from another company. Now, titanium comes in 2 phases, or depending on how it's melted. There's an alpha phase and a beta phase. The alpha phase is the strong phase, and that's represented by the color red. The beta phase is the softer phase, and that gives titanium its ductility. So you want a lot of alpha phase and very small beta phase. So what you see here in specimen A and specimen B, that the red, which represents the hard phase, and the blue, which represents the soft phase, are pretty similar, okay? What electron backscatter diffraction does for us is allow us to look at the orientation of the crystals, okay? So this is the orientation of the crystals in specimen A. You can see the crystal structure is very small here, okay? But this is the orientation of the crystals based on the Kikuchi pattern. I won't get into the complexities of that, but these are the crystals, but the way they're oriented, okay? And this is the orientation map. So this means whether a crystal is sideways, long, short, needle-like, or whatever. And if you look at the 2 different companies, this is an orientation that's pretty nice. It's called a bimodal distribution. It's pretty similar. But if you look at this crystalline structure here, there's a needle-like structure, which is represented here. These are crystals that are in sort of a needle form. Why is this important? Because if there's a crack or corrosion that develops at the surface of this, it can propagate along this type of a crystal structure. So that's why it's important that we understand what these metals are all about. So let's advance. So the conclusion from this study was that the alloy microstructure has a profound impact on the wear, fatigue, and corrosion properties of any device. Now, as I said earlier, we not only have particulation of the material itself, so particles of polyethylene and particles of metal can actually come off, but we also have ions that come off. And the ions are the most concerned. And I don't have a lot of time to talk about that, but we know that, we know from our studies that when these ions come off, they affect the macrophages. They're also carried by cells into the systemic circulation and are deposited in the kidneys, the brain, the heart, and the liver. So what we said, let's look at, we as oral and maxillofacial surgeons put a lot of metal in people. So we designed a study to look at the serum level of these metals in patients who had undergone orthognathic surgery, patients who had undergone total joint replacement, and patients with dental implants. And this is what we found. Okay, so we had a control group that had no patients with any of these metals in. In orthopedics, if you have 2 to 10 parts per billion of cobalt in a device that shows up in your serum, that means that the device is failing. So if anything goes over 2 to 10 parts per billion, that's a problem. So here's our controls. Here's our orthognathic patients. And as you would expect, since most of our orthognathic materials that we use for fixation are titanium, the titanium level, which is the blue here, would be the highest. This patient, we don't quite understand why she had so much cobalt in hers. We're still trying to figure that one out. So she was the outlier. But with temporomandibular joint replacement, you can see the chrome and cobalt ions went above the normal reactive range of 0.7 parts per billion. The interesting one was the dental implants. So this is our dental implant group. Their titanium levels were very high, well over the normal reference range. And that makes sense because when you put a dental implant in, it's under load all the time. So you would expect ions, titanium ions, to come off. Now, do titanium ions cause a problem? There's been some nice studies done in Brazil looking at the osteoblasts around dental implants that show that what happens is the titanium ions are picked up and stored in vacuoles within the cytoplasm and really don't do anything. The problem here with cobalt is that cobalt has multiple ionic forms, some of which actually get into the nucleus of the cell. So we're real concerned about cobalt. But again, that's a whole other story which would take hours to talk about. So what we came to the conclusion with this study is that we need to study this more. Let's talk about manufacturing. Let's talk about 3D printing. This is the hot item. And as I showed you in that slide where we looked at all the devices, many of the new devices are being 3D printed. Why do people want to 3D print? And it's called selective laser melting is what most people are doing. They want a 3D print because you can make materials like this. This is an octet stress lattice structure. This is obviously a much larger device, but you want to improve osseointegration. That's what everybody's after. Reduce elastic modulus and related stress shielding. So you develop a porous 3D printed titanium alloy, which is this. That's what you're after. And that's a great idea. The problem is that these pores, depending on their size, create a low density material. Low density materials tend to crack under pressure. The variable thermal changes that occur during 3D printing because of the laser and the way it hits the melted metal, you can get deformation. So 3D printing, while it's a great idea, is still in its infancy. And we have a nice study going on in our lab now looking at 3D printed orthopedic devices. And 3D printed or using the electron backscatter diffraction, we found that some of the spine devices that are 3D printed are cracking because of this low density. So it's not all, it's not to make a pun, it's not all it's cracked up to be. And finally, ultra-high molecular weight polyethylene, which is the bearing surface of most orthopedic devices because of its hydrophobic content. Okay. But if you put ultra-high molecular weight polyethylene against bone, there is no binding. And typically what you get is a mantle of fibrous connective tissue, which means that that material is never stabilized. And my colleague at Rush, Nadim Halab, has written a ton of stuff on the relationship of of ultra-high molecular weight polyethylene to wear. And the other issue with ultra-high molecular weight polyethylene is that if you put screws through it, as I'll show you in a clinical case here in a couple minutes, you're going to get cold flow. And if that device is not solid against the bone, the screws going through that device are going to fail. So what did we learn from that big study that we did of emerging devices? We learned that it's important for patients, for surgeons and patients to understand what's going on with these devices and why a titanium wrought device is better than a cast device. So these are the surgeon-related failures. If you don't understand this stuff, because if you misunderstood the biomechanics and the materials, you position the materials wrong or you fixate them wrong. And as I said earlier, this is the greatest source of unrecognized variability in alloplastic reconstruction. So let's learn from the mistakes of others so we don't make them ourselves. So positioning in the scanner. If you're doing a custom device, okay, you have to be sure the patient is positioned in the scanner from which the model will be made, from which the design will be made, from which the devices will be made. And this is a custom device where the patient is in occlusion when the device is put in, but the device is not in the right position because the patient wasn't positioned correctly in the scanner. So garbage in, garbage out. Here's one where the device is not positioned. This is a stock device, not positioned correctly. Okay, part of it is in the patient's mouth. This should be back here someplace. And you can see because it isn't positioned correctly, the patient ended up with an open bite. This is the worst one of them all. This is a patient with a custom device where the fossa, here's the articulation. The ramal component is not at all down on the bone, which is one of the advantages we talked about of a custom device. But, sorry, these slides are not advancing. Oops, I don't want to go that far. Okay. Here's the ramal component, which is not anywhere near where it's supposed to be. But look at this is the fossa component. This is the metal part of the fossa component that's supposed to be against the temporal bone. This is the polyethylene component, which is the articulating component, and this is the posterior aspect of it, that the condyle component is now. So this thing is not only in upside down, but it's in upside down and backwards. Okay, that's the surgeon's fault. That's not the company's fault. Here's another one where the fossa component is not flat down on the bone like it is on this side. And so you get a trampoline effect here. This is all fibrous connective tissue. It will not support forces of occlusion, so it will crack. So these are the implant errors you need to avoid, whether you're using a custom device or a stock device. Number one, the medial portion of the fossa has to be down on bone. The CT scan with a custom device does not read soft tissue. It only reads bone. So if you don't get this flat down on the bone, you're going to get that trampoline effect, and this thing will fracture with time at this point. The second thing is you have to adequately remove enough bone at this area right here. Okay, whether you're using a custom device or a stock device, it has to lay flat on the bone. We talked about the importance of the top screw. This is the moment arm. This is where physically you get the most force. And you have to place the rest of the screws, but you can't use screws that are too long. What we found out very early on, 30 years ago, was that if you place screws that are too long on the ramal component, you're getting into the medial pterygoid muscle. And patients will come back complaining of pain at the angle of the mandible, because every time they move their mouth, that sharp tip of the screw is into the muscle. The same thing happens up here with the temporalis muscle. If you put too long of a screw in here, it's going to get into the temporalis muscle, and every time the patient functions, it's going to hurt. This is what they're supposed to look like. Okay, we're supposed to have the medial of the fossa down. We're supposed to have adequate bone removal so that this will come over, and on and on. The advantage of a custom device is that they tell you how long the screws should be. You need bicortical screws. If it's a 10 millimeter screw, you only use a 10 millimeter. A 12 is not going to make it stay any better. Okay, so it's important that you put all the screws in for the reason that I explained earlier about the top screw needs support. There was an article in the AAO or Journal of Oral Surgery a few years ago from the Mayo Clinic where they said, there was no reason to put more than 4 screws in a custom device. They're wrong. They're absolutely wrong from a physical standpoint. The other important thing is that when you're putting screws in, be sure you use irrigation and you use a drill guide. The reason for the drill guide is to position the screws perpendicular to the plate. That's extremely important from a biomechanical standpoint. The reason for the irrigation is for the same reason you use irrigation when you're putting dental implants in. You don't want to burn the bone that is going to be the support for your screws. And you take a confirmation image in the OR. You can see this patient is still in the OR. There are clips for the drapes, tube is still in, and we take a confirmatory X-ray to be sure that we've got the device in the right position. Better to know you've got it in the wrong position at this point than after the patient is awake and you have to take them back to the operating room. Finally, limitation of technology. If you approximate the fit, you're going to get micromotion, which means the components are going to loosen and the device is going to fail. The mandible is not straight up and down. There's typically a yaw or a bend to it. It's not straight up and down. So if you take a stock device and try to place it in, all stock devices are straight, unless you have one with a swan's neck. And in this patient went for 3.5 years with this failed device that was never in the fossa. And you can see where it rubbed against the screws and the plate. Here's another one. This surgeon tried to bend the device to get it to go into the fossa. This is a problem that tried to put a screw in where there's no bone. If you have a screw that is loose or it will not stay in place, don't put it in. Loose or screws that are not in bone do no good. Bending a chrome cobalt device, for the reasons I talked about, this is a cast device, this will break it. Never bend these devices. And this is metallosis because of the metal-metal articulation. This is that fibrous connective tissue that develops from micromotion. Get that micromotion, it loosens the screws. When the screws loosen, the device starts backing out. Here's putting screws through ultra-high molecular weight polyethylene. You get osteolysis. The polyethylene starts moving. The ultra-high molecular weight polyethylene starts moving. Because of the cold flow, the screw now is in that polyethylene. The screw starts loosening and creates osteolysis. And once this screw goes, the next screw goes, the next screw goes, and pretty soon the whole thing is loose and the device fails. Posterior dislocation. We see a number of these with stock devices. The reason for this is that stock devices don't have a posterior lip. And where we see this most is in patients who have combined orthognathic surgery and total joint replacement, which is much more common these days than it used to be. There is no posterior stop here. So when you push the mandible back, it goes right into the ear. And so patients come in complaining of earaches. Custom devices, all custom devices have a posterior stop. That's extremely important. So if you're doing combined orthognathic and TMJ surgery, you need to do a custom device. Using the wrong reconstruction system, okay? This is a huge gap. You can't use a stock device to cover that gap. That has to be a custom device. There's some other wrong reconstruction systems being used. I mean, these aren't even close. Here's one where it's articulating on the mastoid process. These are the wrong systems to be using. So This is a paper that came out of San Antonio where they looked at the stock prostheses have a higher likelihood of failing adequate fixation in mandibular advancement cases, orthognathic cases, greater than the 35 millimeter gap, more acute projection angle in dysplastic mandibles, syndromic patients or craniofacial cases, because you need a device that's made specifically for that case, concomitant orthognathic surgery cases for the reasons I mentioned, and multiply operated patients. So what are we doing? What have we done with research and where are we headed? Just about finished. These are our past collaborative research projects. And as I stated when I began, my interest now is to put some science behind what we're doing. Therefore, I'm happy to be with an orthopedic group at Rush who are pioneers in they're putting science behind orthopedic joint replacement. We're now putting science behind temporomandibular joint replacement. We looked at the electrochemical changes that occur with TMJ devices. We looked at wear and corrosion. We looked at retrieve devices. We looked at adverse local responses. We looked at a finite element analysis model, the serum metal levels that I discussed, hypersensitivity, which is, as I said, is a huge issue. We're looking at engineering. These are the investigations we have in process. We're looking at the TMJ osteoarthritis. We're looking at heterotopic ossification with some of our colleagues, both in Canada and here in the US. We're looking at 3D printed materials in our electron backscatter diffraction lab. We're looking at craniofacial microsomic syndromes, both what the results of costochondral grafts and the results of alloplastic replacement. We're looking at biomechanical function of the unoperated side in unilateral cases. We know now that only 35% of unilateral cases go on to total joint replacement on the opposite side, and only if those patients had a prior temporomandibular joint problem on the contralateral side. We're looking at a new finite element analysis study with colleagues in Germany. With our colleagues in Oklahoma, we're looking at bioengineered condyle prosthesis, which may be the wave of the future. With our colleagues in Canada, again, and our colleagues here at Rush, we're looking at the use of iridium laser for removal of bone. We're looking at biomechanical instability of the temporomandibular joint, meaning the disc is probably not the total answer to the problem. We're looking at why are surgeons being sued? And interestingly enough, we're looking at, with some veterinary people at the University of California, the use of these devices in veterinary medicine. And the reason for this is that the arrogance of success is to think of what you did yesterday will be adequate for tomorrow. So we're trying to make new pencils, I guess. I can't end this without thanking my colleagues at Rush, both at the academic center and at the orthopedics department. I also want to thank my colleagues at the bioengineering department, my colleagues at the Institute of Biomaterials Nanotechnology Tribal Corrosion, and this is part of our research group. Really great people that I'm working with. This was obviously a few years ago before I got old, but again, I want to thank all of you for your attendance in today's talk. I hope it lends some information, and hopefully you'll have some questions for me. If you put them on the chat, we'll try to answer them. So thank you again.
Thank you, dear Lois Mercurii. Thank you for your excellent presentation. It was really wonderful and useful. We can ask our participant, if they have any question, they can unmute the mic and start talking. I'm seeing Dr. Ajoy, Dr. Paramod, and so many other friends are there, and some of the Iranian colleagues. If any question you have, you can ask the professor.
Yeah, if you put them in the chat, I have the chat open.
Yes, they can put on chat, or they can also directly start talking from here also, if they like. Dr. Paramod, Dr. Ajoy? Waiting for some of them if they start asking questions. I got one question regarding total joint replacement. Anybody want to talk?
Someone's trying to talk.
Yes. According to your really long time experience on total joint replacement, what do you think if somebody want to start as a beginner, what kind of software they should use, and what company, and it's better to use the custom made or a stock made TMJ?
Hi,
what is your opinion?
Well, first of all, I don't think you should start without taking a course.
Yes.
I think most companies now, and I know for sure TMJ Concepts requires that you take the didactic and cadaver course that we provide at many places around the world. Now we used to do them in London and Czech Republic. We did one in Vienna. We had courses scheduled for Saudi Arabia, but with the COVID, we can't do those courses anymore.
Yes.
So that's the most important thing. So if you can't go to a course and you want to start doing this, I would suggest that you find a surgeon in your area who is doing this, who has experience, because all those cases that I showed that were failures and where the devices were in wrong and put the wrong device in, those were people just starting out who didn't really understand the process. We call them onesies, people who do one case. So find someone in your area where you can go and watch them do surgery, watch them do these cases, okay? Now, when things open up and you can get to a course, that's great. Yes. And then when you go back and you start doing this, custom devices are much easier to place than our stock devices for the reasons that I mentioned. You don't have to make it fit. Now, Biomet does make a custom device. It's not approved in the United States, but it's approved all over the rest of the world. So you have choices. You have either a Biomet device, custom, or the TMJ Concepts device, custom. The difference is that the Biomet device has an all polyethylene fossa. There are no orthopedic devices that have ever been developed that have an all polyethylene fossa for the reasons I talked about, the cold flow, the creep, the fact that it never solidifies against the bone. Whereas the TMJ Concepts device has a metal-backed polyethylene fossa surface. So it integrates with the bone and it prevents the flow, cold flow and creep of the polyethylene, just as orthopedic devices. So those are the two choices that you have. So if you're going to start out, you go watch somebody do an operation or operations, you come back and you say, I have a patient. Which patient should you start out with? You should start out with the simplest possible case, not an ankylosis. Okay, that's the hardest case. So the simplest cases are the ones of either a fibrous ankylosis, low inflammatory osteoarthritis case, where you have some anatomy to work with. You don't have to make anatomy. Rheumatoid is a very good one to start out with. In fact, I've suggested to people when we do the courses is to go back and talk to their rheumatology department, because about 18% of patients who have systemic rheumatoid arthritis, and it may be higher, have TMJ involvement. So talk to your rheumatoid colleagues. See if they can provide you with patients. They're easy ones to do because they have a defined anatomy. So those are my, that's a very long answer, but COVID made it long. Otherwise, I'd just say come to a course.
Yes, hope we will have you in Iran also for the course.
I think it'd be difficult for me to get there.
Yes, that I hope that sanction also will over. That after this another 1 year, I think everything will be finished. One of our colleagues asking a question: what about the TMJ replacement in the growing patient?
Yeah. Well, in the growing patient, we've been using it. That paper that's been published in the International Journal in the latest issue, if you go online to the International Journal and look at our paper there, gives you all the details. The reason it seems to work is because of Moss's functional matrix theory. Moss's functional matrix theory says form follows function. So if you get the patient functioning, they seem to grow. And the reason the mandible grows in those situations is because it's appositional growth caused by the pull of the muscles of mastication and the muscles of facial expression as the patient functions. It pulls on the periosteum, so you get appositional mandibular growth. The patients who did not grow in that study were the craniofacial patients, hemifacial microsomia patients, because they don't have the muscle matrix. You remember the hemifacial microsomia patients, because of the nature of the etiology of the disease process, they don't have the masticatory muscle as well as the bone. So if you put a metal device in them before they're matured, they're not going to do well. Now, once they mature, we have a study going on now at Rush with the craniofacial department there, putting these devices in mature craniofacial hemifacial microsomia patients. Those patients are doing extremely well, much better than the costochondral graft patients. So we're starting to call back the costochondral patients, see how they're doing. So yes, it does work in those patients, but we need to have more studies. The other question that was here was, I'm using 3D printed titanium joint with ultra-high molecular phosphorus. Surprisingly, the serum chromium levels are shown higher value in such patients. What can be the reason?
Question is from Dr. Ajay from India, yes.
Serum chromium levels are shown to be higher value in such patients. That's interesting.
Not one, at least I've done about 8 of them, and all 8 are showing serum chromium levels, which is increased, which is very surprising.
Yeah, so I wonder if is your FOSSA component backed with a chrome cobalt?
No, it is ultra high molecular, same as Biomed actually.
Wow, that's unusual. Although it is interesting, if you look at the data that I showed you on our orthognathic patients, where we looked at serum levels, we had one patient with high cobalt, and we couldn't figure out. Now, let me go back. There are a number of things that, and I can send you the list, I don't have it off the top of my head, a number of things that give patients high cobalt levels that you wouldn't suspect. Certain medications and things of that nature, certain careers, certain jobs that they have, they work around metal, certain cosmetics that they use. So I'll send you that list, and you can look at the history of your patient. But that's an interesting finding. I'm going to go back and talk to my colleagues and see if I can come up with an answer for you on that one. But that's a good one.
So what we have done now, we're taking the urine samples as well and trying to see if we can correlate something in that. And now we are taking the preoperative values and 1 week and 3 months. So we're looking at that I'm still not able to find out the reason for that. Yes.
Yeah. So what are you finding in your pre-op? Or you haven't analyzed those yet?
No, we haven't analyzed that.
Okay, because that would be interesting in terms of the other things that, the cosmetics and the
Yeah,
jobs these
maybe.
people do. And there's certain vitamin B shots, for instance, will increase your cobalt level. So there are a number of things. I'll send you that. And I have your email from the internetwork.
Yes, yes.
Okay, good. Thank you. That's a great question.
Thank you.
Get my mind going here.
Yes, it's very good for research. Dr. Dr. Parris, any question? Dr. Parris is a director of our education in our association, and he's doing some cases. He have done some cases of total joint replacement with his colleagues from engineering university. Please, Dr. Parris, you can start yourself.
Hello, Professor Mercurii. Nice to meet you. I appreciate to accepting the invitation of Iranian Association of Oral Maxillofacial Surgeons. And thank you for your nice presentation, very complete. It was great for me. A lot of points I learned. I have a question. During your presentation, you tell that we have to control the porosity of the customized TM joint processes, because maybe some cracks will happen, or during 3D printing, some misshape of or disfigurement may happen. Am I right? Is it true?
Yes.
So
yes.
You mean that the control of porosity is much more important than the weight of the processes? It doesn't matter about the weight of the processes?
I think that, titanium is so light anyway that, I think what the idea was behind the 3D printing was to create that lattice that had more pores in it. The issue will be increasing the strength of the lattice struts so that they're not as thin. So that when you create porosity, that the pores may be a little bit smaller.
Yeah.
They'll be greater than what we have with forged titanium. Okay, you'll have better porosity than with the forged titanium.
Yeah.
But the strength of the lattice has to be made better. And that's what we're looking at now. The other issue that I'm concerned about with the porosity is that, these devices are not going to last forever.
Yeah.
And to get these devices out without porosity is very difficult.
Very difficult because the fibers tissue grows.
The bone grows into them.
The bone grows.
Then you got, bone grows into the head of the screw. So you can't get the screwdriver in to take the screw out. So you have to drill the head of the screw off to get it out, which puts metal all over the place.
Yeah,
so
that's right.
That's why we have started this study using the erbium laser. The erbium laser will cut through bone, but not damage. We don't know yet, and that's why we're doing the study, without damaging the metal. And if it does damage the metal, we need to know how it damages the metal. So, the erbium laser may be, of help. It's extremely expensive. Not every hospital has it, on and on and on and on. But porosity is a two-edged sword.
Yeah.
So I'm waiting to hear how people are going to get these things out. Same thing goes for threaded screws. Where does my 78-year-old brain is going away here?
No problem. You are very good.
Well, anyway.
Thank you so much.
Thank you. Dr. Louis, please, a few months back, you got a presentation with India, I think. Asked a question regarding how long it will work, this total joint replacement with the custom made. And you said that there is a 30 years experience in Chile and If you have this article, can you please send again to us? I missed it that day.
Sure. Yeah, we have the 20-year follow-up. It's a 20+ year follow-up. I'll be happy to send it to you. If you, I have your email, so I can send it to you, and you can pass it around.
Yes.
We're doing a 25-year follow-up. The problem that we're having, as you're well aware, and maybe we have a bigger problem here in our country, so people move around. You know, they don't stay in one place.
Yes.
And in many countries in the world, in fact, most countries, most other countries in the world, certainly the ones I've visited, people tend to stay close to where they were born and where they live. And there are generations that live in the same city. They never move, you know, and maybe the same thing is true in Iran.
Yes.
But it's not
Definitely.
true here in this country. People move for a lot of reasons, mainly for work. I moved to get away from my parents, you know, that kind of thing. No, that's a joke. I love
It's
my
okay.
parents.
It's good.
But you know, for jobs, you move. I mean, I've moved 3 times for jobs. So what happens is trying to find these people. So when we did our 20-year follow-up study, we had to track all these people down. We found of the, well, I don't know, there were 300 or 400 patients in our original study from 1995.
Yeah.
We could only find 100, right? Because the other 200, a lot of them were women, so they changed their name. We had their social security numbers, which you can't use anymore, which is their identification. You can't use that anymore because of all the online stuff that's going on with social security numbers. We could only find 100 patients. So I'm wondering if we're going to be able to find even 100 when we do 25 years now. It's very difficult to do these kinds of studies. So that's why I'm hoping through the American Society of TMJ Surgeons, the European Society of TMJ Surgeons, the South American, the Japanese, that we pool our data and start looking, you know, at a worldwide thing. And that's why we started that paper that was in the British Journal with my colleagues in the UK, to look at all the devices that are being made around the world so that we can sort of bring that data together so that we understand it more. And my colleagues in India have been very nice to, you know, they're going to provide us with some 3D printed devices so that we can look at them in our study. I have colleagues in Brazil and in Chile who are also willing to provide us with devices, and a colleague in Australia. So we'll be able to do some of the studies on those 3D printed devices to look at the porosity issues and some of those other kinds of things. So I think if we can all come together and agree that it's for the benefit of our patients that we do these kinds of things and we do some science, we won't get into the trouble that we got into with Proplast Teflon and silicone rubber.
Thank you. And one more question regarding the synovial joint. Last time you said the synovial joint itself, it will produce in the case of total joint replacement in
Yes.
one of your presentation. Is it
Yes.
true? How it will happen exactly?
Well, whenever you implant anything in the body, it develops a fibrous connective tissue capsule. When you implant a joint, you probably don't remove all of the synovium and all of the cells that develop synovium. In fact, one of the macrophage studies we're doing is looking at that. And when you reimplant an artificial joint, the synovium regrows, and you get what's called a neosynovium. Now, it may bring along with it some of the macrophages that were in the original joint, and that's what we're looking at, because what we found out, at least in orthopedics, is that if you have a patient who has degenerative joint disease or osteoarthritis, and you catch it early, and you operate it early, and you put a total joint or total knee in, for instance, that patient does a lot better and maintains that joint for a lot longer than a patient who has a stage 4 osteoarthritis, which is the worst. Be like a Wilks stage 5, okay, in the knee. And so we started looking at that with TMJs, and we found the same thing. If you catch osteoarthritis early and you operate the joint early and put a joint replacement in, those patients do a lot better than the patient that you wait until they get to stage 4 TMJ. We wondered why. Why is that? And the reason for it, at least in orthopedics, appears to be that you take some of those macrophages, the M1s, and they convert to M2, which are destructive macrophages, and you bring them over into the new joint, they start destroying the new joint. Whereas if you catch them early, the M1s are still there, the M2s haven't formed. So the point is that you do develop a neosynovium around a joint. We have a couple papers on that. I'll be happy to send you those as well. And this is a two-edged sword. Again, because what happens is, at least in orthopedics, and we're finding this to be true in the TM joint as well, is that synovium develops in folds, okay? Now, as these folds develop, some of them develop into what are called plica. And this is work that was done by Ken Murakami in Japan. These plica can get trapped between the articulating surfaces of a joint. So it's synovial tissue that forms like a tongue. It gets caught between the bearing surfaces, and it starts to become inflamed. When it becomes inflamed, it starts to hurt. Okay, so you get inflammation, redness, pain. And so what we'll see in the knee is a patient will come in and they'll complain that either the lateral or medial surface of their knee replacement is swollen or it hurts. Go in with an arthroscope, which is much easier in a knee than it is in the TM joint, and you find these synovial plica that are trapped. And again, this is called synovial entrapment syndrome. And what you do is you cut that off with the scope, and the patient does fine. So we brought that idea to Joe McCain, Howard Israel, and we said to them, you know, those are the two best arthroscopists in the United States. We said, are you willing to scope a TM joint prosthesis to see if you can find these synovial plica or entrapments? And they did, okay? And there's a nice paper that was written on that just recently that was in the Journal of Oral Maxillofacial Surgery that showed these synovial plica. So that really proves what we've been talking about all the way along, that yes, you do get this neosynovium, and yes, that neosynovium can react, and yes, you can get these plica that develop. And actually tomorrow I'm giving a presentation on a new hypothesis we have for why patients have TMJ pain, that it's not the disc, okay? It's
very good.
It's this inflammatory response that they get, which is the orthopedic response. You know, we need to go back to orthopedics. We got to stop talking like dentists, right?
Yes.
Because dentists think there's only one way to manage everything. And so we got trapped with this disc thing back in the 70s. And when you only have a hammer, everything looks like a nail. So everybody thought it was the disc all the way along. It's not the disc, it's the synovium. It's all the things that orthopedic surgeons have been working on for years that we have fallen so far behind. So Joe McCain, Howard Israel, Ken Murakami, and myself, and a couple other people have been really working on the synovium business. There's more to it than we've made of it. And I think it's important that we put that out. And I'll be happy to give that disc thing to your group sometime, because
yes.
I think it's something we all need to be thinking about. it's not the answer. Okay, but
It
I think it's
is.
the next step for us to be taking.
It's very good. It is in case if the course you are going to present tomorrow, if it is free, you can send us the links also. We can share with our colleagues. If it is
Okay.
thank you. And I should thank Dr. Bayat, is our ex-president of Iranian Society of Oral Maxillofacial Surgery. He is joining us. Dr. Bayat, please, if you want to ask any question from Professor Louis, we will be very happy.
Thank you so much for your efforts, Dr. Nawab and Dr. Parris. I'm so
Thank
happy
you.
to meet again Professor Mercury after 10 years. We have been in Turkey for American refresher course with George Obeid and Amit Shafi.
Yes. Yes.
I think you remember that it was a very
It was
nice
a wonderful,
course.
wonderful time.
Yes, yes, it was very good. I want to say many thanks to you. I don't have any question. Usually, Professor Mercury presentation is
excellent. Yes,
nice and informative. I'm so happy to meet.
Thank you.
him again.
Thank you.
Thank
Dr.
you.
Louis, please, you said in one of your slides, nowadays so many people are using orthognathic surgery along with the total joint replacement.
Yes.
What are the cases they use? Usually, I think in the juvenile idiopathic arthritis or ankylosis, what I think. What are the other cases may they need a total joint replacement along with the orthognathic surgery?
Rheumatoid patients, patients that have severe osteoarthritis, where they have a compensated maxilla. You know, it's been going on for so long that they get maxillary compensation. If it's a unilateral case, if it's a bilateral case, they end up with an open bite. You know, so it's those kinds of cases. The other ones are the craniofacial cases, because there you've got a maxilla that may have to be moved. And again, with the craniofacial cases, we're talking about skeletally mature. Okay, you can't do a craniofacial case in a skeletally immature patient. And I see there's a question here from Matthew. Would you suggest total joint replacement in a growing child? At what age is the limit? The youngest one, if you see that article that's in the International Journal, that patient was 6. Now, that patient had undergone 2 rib grafts for an ankylosis after trauma. So that was the reason for that case. Piero Cascone in Italy has done, I think the patient was 5. Again, it was a young girl who had been dropped as an infant, and in the delivery room. It was delivered and fell and dropped, sustained bilateral condyle fractures that no one recognized, and she developed an ankylosis, and she wasn't thriving and had obstructive sleep apnea. So there's another patient. Obstructive sleep apnea patients are good examples for orthognathic surgery as well as total joint replacement. So there's a number of reasons for it. And with VSP now, virtual surgical planning, has become pretty easy to do these combined cases, because both Zimmer Biomet and TMJ Concepts work with all the VSP companies, Material Ease, KLS, any of the ones that you use. And the engineers work together to devise the device that will fit the case. So reasonable.
Thank you so much. Any other, if they have any question regarding the presentation, we'll be happy. Dr. Ajoy?
Hi, Ali.
Yes, Dr. Paramount. Please start your asking.
Hi, Dr. Mercury, this is Pramod. We had interacted during the Indian Association, the talk that you had given for the Indian Association.
Yes.
Yes. Question?
Yeah. I have a question for you. Yeah. So, what about TJR during construction? For example, when you have resected and you're doing microvascular reconstruction, what about replacing a joint along with microvascular reconstruction?
Dr. Paramount, can you repeat because you are not very well audible?
My question is, what about reconstruction, TJR, along with microvascular reconstruction?
Oh, okay, yeah. It certainly works. The extended custom TMJ devices that are used for mandibular reconstruction certainly can be used in combination with microvascular. And there are some people, I think Luke Cascarini in London has done some of those cases. And I think he wants to present those, but he's waiting for the long-term follow. I think where that technique is best used is in patients that have poor soft tissue coverage or osteointegration necrosis patients where you have such poor tissue that placing any device or any reconstruction will cause failure. So sure, yeah, you can use those. The only person I know right now is Luke in London. Sure, it can be done. Again, if you do it with the VSP,
okay,
and work with either Biomet or TMJ Concepts, they can design a device that will work perfectly with whatever the VSP for your fibula.
right. Thank you. I have one more question.
Okay.
See, custom design joints, which are FDA approved, are not available in India. What is available is stock Biomet and companies printing, which are not FDA approved. Now, as you said, the stock what we have is chrome cobalt molybdenum condylar component and ultra high molecular weight fossa component, which do not, as per your lecture, they are not the ideal materials to use. But we have no other choice. So, what would be your advice in this setting? They're forced to use this.
Again, you broke up so much that I think your question was, and correct me if I'm wrong, that you don't have custom devices, you have stock devices. What do you do with a complex case with a stock device? Is that your answer question?
Not exactly.
Oh.
My question is the stock device that we have is the Biomet chrome cobalt molybdenum
Right.
container and the ultra high molecular weight fossa component, right?
Right.
Are probably not the best things to use, right? And our custom joints are still experimental, okay?
Yes.
So we are forced to use, even the custom joints that we have, use ultra high molecular weight polyethylene fossa components,
Right.
which are not titanium backed. So in such a setting, being a third world country, it's going to take a long time to get up to your standards. So would you suggest that we keep on using the what we have? Is it okay to use them?
Yeah, well, I mean, yeah, I think it's important that if you're using a non-metal backed polyethylene fossa component, that you're absolutely sure that it is as stable as possible. And if you stabilize it really well, it's not going to move. It's not going to develop that micromotion that I talked about. And that cold flow property is lessened. All right. So you just have to be very meticulous in placing that faucet. And, I understand, I spoke with someone, I can't remember where they were from recently. I think it was South America. And they said they're trying to figure out how to put metal on the back of ultra high molecular weight polyethylene to develop a metal back fossa, and they can't figure out how to do it. TMJ Concepts figured it out and patented it, and so it's a secret. And if I tell you, I have to kill you, kind of thing. So yeah, I mean, people are working on it. People are working on it. It's just going to, and somebody will figure it out. Somebody figures everything out. But just be very careful that you stabilize that fossa as best as you can.
All right. Thank you so much.
Thank you, Paramount. Our president, Dr. Rastapar, also is in our meeting. If any question, Dr. Rastapar, please, if you are here, you can say anything, any words? I think he's muted. Dr. Ajo, you wanted to ask some question? And Dr. Garibano from Italia also is there if you want to ask any question.
Yes, Lou, do you
Yes.
prefer a single stage TJR orthognathic surgery in an ankylosing case or a two-stage?
Oh man, interesting that you asked that question. To me, there are three ways that people have handled that. One is a two-stage, which is what I prefer doing, because using a custom device, you want it to fit as best as possible. So the two-stage is what I always did and would continue to do. Now people are using virtual surgical planning to develop cutting guides and fitting guides, which is a reasonable thing. But what I've heard from some of my colleagues, and we're going to do a study on this, is that it comes close, but it's still really not a custom once they get it. It's, again, they have to kind of make it fit. So that, and then the third group is people who just wing it. They just go, they order a custom device and they just try to make it fit. So they make a custom device, a stock device. So I would always do a two-stage. I was so happy. I never had the problem. Being a consultant for this company, I see all of the disasters. That's where a lot of those slides that I show come from. And I could spend the rest of the day. It's amazing what the problems that people get themselves into because they don't follow the directions. We're surgeons. And we're like fighter pilots. We have to get to the edge of the envelope. How far can I go without falling off the edge? And so these guys do all this crazy stuff, and I just can't believe it. Whereas if they just followed, as in my cases, and I don't know how many hundreds and hundreds of these I did as a clinician, I never had the problems that these people had. And you probably have the same. The more experience you have, the less the issues are. So that's why the first question that I got was about how do you train someone? You gotta get into either working with someone who does this all the time, get into a course or something, but just trying to do it on your own, that's a big mistake. And what I'm concerned about is that if we have a whole bunch of failures, we're going to all be painted with the same brush. Everybody's going to look at us and say, well, then everything that you're doing with this is a failure. And you're like the ProPlast Teflon, like the silicone rubber, And so, I've got into arguments with companies where I've tried to get their devices just because we want to look at them scientifically. They say, oh, no, you work for that company and you're going to take our device. No, we got the best device in the world. Why would we take somebody else's? I want to do some science. I want to find out, like those electron backscatter diffraction things. Those are 3 different companies. Okay, one of those is TMJ Concepts.
Yes.
So, when we write that paper, it's going to be, and any paper we do or any devices that people send us to look at, those papers are not going to say, this is from, such and such, this is from such and such. That's not our point. the point we're trying to make, like I tried to make with those titanium slides, is that if there's an alignment of those crystals that can perpetuate a crack or corrosion, that's important for us to know. That's important for that company to know, because that's going to make that device eventually fail. So it's those kinds of things that we're doing. Whether we're right or wrong, we'll find out.
Thank you. One of our participants asking, what are the kind of spacer used at the defect site if a second stage of TGR is planned?
Yeah. I always, well, you can use, there's a number of things you can use. Larry Wolford recommended an orbital silicone. It looks like an eyeball. Like if someone has to have an extirpation of their globe, they put a spacer in so that they can make the false eye, and it's made out of silicone rubber. You can use that. I always use a block of silicone, medium grade silicone. Orthopedics uses it all the time, plastics uses it all the time. So every hospital has it. And what I would do is I would do my resection for the ankylosis, shape my bone, and then design my spacer using a scissors and a number 10 blade to make it look like the device that I'm going to put in. And the reason I did it that way is that it developed a nice fibrous connective tissue capsule around it. When I went back in, it was easy to pop the spacer out and put the device in. And I left the capsule around it because that prevented the development of heterotopic ossification, that and fat graft, and all that stuff. So that's something you can use. The third thing you can use is polymethyl methacrylate cement, orthopedic cement. What you do there is do your ankylosis, do your gap. And by the way, your gap has to be at least 2 to 2.5 centimeters, because osteoblasts can swim, they can't fly. Put the patient in fixation and just take the polymethyl methacrylate, make it into a dough, remembering that it has an exothermic reaction. So you have to really cool it off when you put it in, and just stuff it in. Just push it in to the gap. And everybody's gonna say, whoa, what about undercuts and all that? Well, when you go back the second time, you take the patient out of fixation, stuff pops right out. It leaves a nice capsule just as well. It works really well. So those are your three choices, unless you come up with something else. Some people have used fat. They fill the thing with fat. I don't like that because I don't like to have to dig through all that fibrous connective tissue to recreate the gap that I already made. The other thing that I learned talking about ankylosis in 2 stages is not to do if you have to do a coronoidectomy, which is very typical in an ankylosed case, not to do the coronoidectomy until the 2nd stage. Because what I found was between stage 1 and stage 2, which was typically 6 to 8 weeks, you get enough fibrous connective tissue attaching to that stump of the coronoid that you've made that it's very difficult to get rid of that, and the patients don't open as wide. So when I started doing just the gap arthroplasty, saving the coronoidectomy to 2nd stage, I got much better function in my patients. So that's a little trick that took us a couple years to learn, but I think is very helpful.
Thank you so much. And if one more question, I think is from Ablish. No, thank you so much, Professor Louis, and thanks for all the participants. If there is no question, we are going to end the program.
Okay.
In fact, it was a wonderful session. In fact, it was a wonderful session.
Thank you.
Thank you so much.
Thank you. And Alireza,
Yes.
I will send you the 20-year follow-up paper, the information about tomorrow's lecture, and
You have sent it to my email? Or
Okay.
send it to my email, please.
Okay. And,
Okay, thank you.
Dr. Alireza, this 20-year follow-up paper is actually a worth read paper because I have followed my joints for just 6-7 years. But what
Yes.
Dr. Mercurii has endorsed is almost astonishing findings.
Yes, yes, definitely, yes.
Yes,
Thank
yes,
you.
yes.
Thank you.
Thank you.
Yeah,
Dr. Reza.
congratulations, Dr. Alireza, for this wonderful session. Thank you very
You're
much.
welcome. Thank you.
Thank
You're
you.
Dr. Reza.
welcome. Yes.
I have one question, one parting question for Dr. Lois Mercurii.
Yes, please.
I think if you can take a question. Lou, I'm Dr. Abhay Kamath from Mangalore.
Okay.
Oh, yes.
Um,
Kamath is very good. He's
eh,
doing lots of TMJ. How are you? Thank you for joining
I'm
us.
fine, Doctor. I'm so happy to be here to listen to
Thank
Lou
you.
again and all my colleagues out there. I just
Thank
wanted an
you.
opinion as to what is Dr. Lou's take on the use of polyether ketone. I hear a lot of people use this as a joint material.
no.
I really wonder.
Well, there's one joint in that series that I showed. There's one joint in Brazil that's made with PEEK. PEEK, there's many different types of PEEK. PEEK is great for cranioplasty for non-weight bearing areas of the body.
Right.
So, but to use it in a joint, my colleague, actually the head of the lab at Rush, wrote a very nice chapter on the use of PEEK in orthopedics. And most of the orthopedic literature, other than from a guy by the name of Kurtz, who's developing a PEEK knee, which is going to be interesting to see how that turns out. Pretty much the orthopedic literature says that PEEK is not the type of material that should be used on the articulating surfaces of joints, artificial joints.
Okay.
And we pretty much go with that. Now, we'll see as companies work on different combinations of material to strengthen PEEK, and we see what Kurtz's outcomes are with his knee, that could change. But basically, it's not a good material.
All right.
The gold standard right now in orthopedics for the fossa component or the articulating component of the stable portion of a joint is still ultra-high molecular weight polyethylene.
Okay. Okay. Thank you, Lou. Thank you so much. Thank you, Dr.
Dr.
Reza.
Yes,
Dr.
welcome.
Kamath, if I can take that, Dr. Alireza, with your permission.
Yes, please.
I should not reveal this at this instance, but yeah, because it is a scientific meet, I would contribute this.
Yes.
In a small rabbit study which is ongoing.
Yes. Yes, you are not audible. I think
Maybe,
yes.
Yeah, this is Dr. Darpan here from India.
Yes,
Yeah,
please.
the PEEK degradation products when compared to the ultra high molecular weight polyethylene products, my little experience which we are doing on rabbit studies now, the PEEK may not sustain for too long. Let's see, let's wait and see. But for PEEK, I would just say that it is under research. Let us not go too much into PEEK currently.
Right, I agree, 100%.
It is under research. Let's say it is just for studies. Let us not get into practice with PEEK currently, because what I found with a little studies on rabbit studies which are going on with my colleagues here, that PEEK may not sustain for too long. It's a hyped up material. We may have to continue with ultra high molecular weight polyethylene, and maybe the more stabilized versions of ultra high molecular weight polyethylenes like vitamin E stabilized and other things, highly cross-linked ultra high molecular weight polyethylenes. So let us wait for the results and not jump into conclusions with PEEK. PEEK is a fascinating material, definitely, but let us wait. I think Dr. Mercurii would agree with me on this.
Absolutely. Absolutely agree.
Let's wait.
Thank you. Thank you for
time being, for our clinical practice, let us continue with what is already established.
Don't reinvent the wheel.
Yes, sir. Definitely. I agree with you. Endorsed from India.
Thank you. Thank you so much. Thank you, everybody. And thank you, Professor Louis, to give a long time with us. And I know you are very tired. Thank you so much. And once again, in behalf of our association, I should say thanks for accepting our invitation and all the participants. Thank you for everybody.
Thank you.
Thank you, Dr. Alireza. Thank you, Dr.
Thank you.
Mercurii. Thank you,
You're
Dr.
welcome.
Kamath. And thank you
Thank
all
you.
for being
Thank
here.
you all.
Thanks a lot.
Thank you. Bye-bye.
Bye-bye. Thank you.